Thank you so much, Ned. It is my privilege to introduce our panelists today, and we will begin with Julia Brody. Julia Brody is the executive director and a senior scientist at the Silent Spring Institute. It's a scientific research organization that studies environmental factors in their relationship to breast cancer. Her current research focuses on reporting back to people who participate in environmental health research studies to give them more information about their own personal chemical exposure. And with support from NIH, her team developed Derby, which is the Digital Exposure Report Back Interface. It's an online personalized web tool for providing individual results back to participants. She's also studying what Americans want to know about endocrine disruptors as part of an emerging field of environmental health literacy. And her interest in returning exposure results grew out of Silent Spring Institute's household exposure study, the first comprehensive assessment of exposure to endocrine disrupting compounds in homes. Her research has been recognized as an Environmental Merit Award by the US EPA. She is an associate editor of Environmental Health Perspectives, and she's also adjunct assistant professor at Brown University School of Medicine. She earned her PhD in communication psychology at the University of Texas at Austin and her AB at Harvard University. Julia, welcome, and we look forward to your talk.
Thank you so much. I'll take a moment to share my screen. Let's see. How does that look? Can you see my title slide?
We do, but we also see your
how's that? Is that better?
Yes, perfect.
Okay, thanks everyone. So I am here today, as Dr. Haynes indicated, thanks to the women of Cape Cod. Some 20 years ago, my team began measuring 87 endocrine disrupting compounds in household air, dust, and urine as part of a breast cancer study to evaluate higher incidence on the Cape. And within days of beginning our field work, our study participants began calling to get their own results. At the time, 30 of these chemicals had never been measured before in the US, so there certainly were no clinical guidelines. And returning individual results with no clinical implications was not routine. But out of respect for our participants, we decided that they had a right to know. Since then, we've partnered with more than a dozen studies to report back on environmental chemicals when the health effects are uncertain, including in studies of PFAS in highly exposed communities, in firefighters, and general populations. And we've interviewed hundreds of study participants before and after they received their results. So thank you very much for this opportunity to share our work so that what we've learned about biomonitoring communications can be translated from environmental health research and integrated into monitoring programs and clinical care. You've heard in other parts of this meeting from community members that they want to have the choice to learn their PFAS exposure levels outside of enrollment in a study, to track their levels over time to see that remediation is working, and to consider medical tests in relation to their PFAS exposure results. And based on our work, I'm confident that personal exposure reports returned through medical care or in public health programs can be designed to provide meaningful information in response to these concerns. I mentioned that my team's starting point for thinking about report back was ethics. Although it used to be common to report only clinically relevant exposures, that thinking has evolved. And at this point, several expert panels in the US and internationally have concluded that reporting back personal exposures should be the norm. 2018 report of the National Academies concluded that although report back should be the norm, it requires dedicated guidance, expertise, and resources, including QA/QC at the measurement stage. So it's not a casual process. But they concluded that the potential harms of report back have been overstated and the benefits are underappreciated. and specifically that the benefits extend beyond the clinic and beyond actionable results and are vital to building trust. These findings are specifically relevant to PFAS because it means that the benefits of exposure monitoring don't require certainty about links to health or knowledge about how to eliminate PFAS from the body, and that access to monitoring may in part contribute to reconciliation from years of pollution. My research team was also influenced by community-engaged research ethics, which sees access to personal biomonitoring data as an equity issue because it supports the right to understand one's own exposure history and make decisions about personal and community-level actions. Because we were in new territory at first, reporting on contaminants without clinical guidelines, I asked an interdisciplinary team to join me in studying the experiences of people who are receiving their personal reports. I was joined by toxicologist Ruth Ann Rudell at Silent Spring, sociologist Phil Brown, who's with us today, Rachel Morello-Frosch at UC Berkeley, Sean Goho at Harvard Law School, and later Harvard computer scientist Krzysztof Gajos. Katie Borno leads our current projects. And at this point, our biomonitoring communication studies include interviews with participants, researchers, and IRBs, focus groups, advisory councils, and stakeholder workshops, observations at community meetings where results are being returned, one-on-one user testing of reports, and now digital analytics for online reports where we can see how people are navigating the information that we give them. This work has been continuously funded by the National Institute of Environmental Health Sciences and also by National Science Foundation, California Breast Cancer Research Program, and CDC. More than a dozen biomonitoring studies have collaborated with us over the years. And I want to acknowledge that others involved in this panel, including Dr. Haynes, have been advancing report back practices too. And I look forward to hearing your thoughts about it. As report back has become more common, we've also seen in parallel much greater openness in genetics and medical care, giving patients routine access to test results and to their doctor's notes, a practice that is now required under the 21st Century Cures Act. These trends help to position clinicians to integrate new forms of biomonitoring in their relationships with patients. And our research about how people respond to report back can also help them plan for the conversations when patients learn about chemical pollutants in their bodies. We call this the exposure experience, the experience of learning about invisible chemicals that you can't perceive, but are within your own body. So how have people responded? We find that people respond consistently with gratitude. They want to get their reports. And when results are returned thoughtfully and transparently, they increase trust. We find a great deal of learning about environmental health without undue worry. Of course, learning about chemicals in your body can cause concern. We find that people integrate these concerns into their lives just as other good and bad things that are going on for them. They begin brainstorming about personal exposure history and about changes that they could make to reduce their future exposure and protect their families. They do reflect on family illnesses, but with an understanding of uncertainty. So we hear people expressing curiosity. I wonder if this illness may be linked to this chemical. And then people will say, but I know you can't make a one-to-one link. People experience a sense of toxic trespass. Chemicals are in my body without my permission, and this is not fair. People can be frustrated by knowledge gaps and that our society has not yet invested sufficiently to understand the effects of these chemicals on health. We find that community context matters in communities that have major industrial neighbors or known to have contaminated drinking water. People are prepared for their personal results in a different way. They have their own assessment of economic and power dynamics in their community, and a sense of what that history has meant for them. And I'll say that I hope there's nothing on this slide that is a surprise to you. These are all things that I've seen happening and you've seen happening firsthand in the public comments to this panel. What I add is to say that these
recording in progress.
These experiences are common across many communities and different kinds of situations. We also find that people use their results in very practical ways. People make personal choices, for example, to get a water filter. They do take their results to their doctors sometimes with mixed results. Sometimes doctors can be dismissive, but sometimes, for example, in a study in public housing in Boston, participants found that when they took their results to the doctor, they got more attentive care for their children with asthma than they had before. We've also seen impressive examples of people taking their personal results into the public sphere and successfully gaining public health protections for their communities. People have gone to public hearings, they contact elected officials, they speak out on social media. You've certainly seen this for PFAS, and we've seen it in other settings as well, with very impressive results, showing how personal results can be empowering for entire communities. So what's a good way to return results? You can't just send people a number. They come to their results with a set of core questions. What did you find? How much? Is that high? A question that's not necessarily easy to answer when we don't have health guidelines. Is it safe? Meaning, what do and don't we know about health effects? Where did it come from, and what can I do? I heard Dr. Maida Galvez state this very succinctly yesterday. What, so what, and now what? So we're trying to design reports that answer those questions. And because it requires both personalized summary statements that bring attention to particular findings for particular individuals and a great deal of contextual information, to make it efficient, we developed Derby, the Digital Exposure Report Back Interface, which is a software framework for generating personalized exposure reports for print, computer or tablet, and smartphone. I'm going to show you examples of the user interface, but there's also a researcher dashboard that allows other people to author reports. So much of what you'll be seeing, the photos and text and decision rules, can be modified by the report author using the researcher dashboard. Derby is designed to be multi-level, so it has headlines, quick summaries, if you want to know the 3 most important things. And then users can navigate to a deeper dive and go to information that's of interest to them, so that it doesn't look like a 60-page report for the person who just wants the quick summary. It includes an extensive content library that can be used or modified, providing context for understanding results. It has multi-language capability. It can be easily tailored with participant and community input. The prototype is designed to be user-centered and has been one-on-one usability tested in a variety of different settings. So now I'm going to show you some examples, starting with computer-based reports and then some smartphone examples. So reports begin with the welcome page, which orients people to what they're going to see. Then they come to an individual login. Derby does not contain any overt personal identifiers. So each person has a unique password to log in to only their report. It can include an informed consent, so people decide whether they do or don't want to see their results. Then users navigate to a summary page with main messages or headlines about their individual and community-wide results. This is an example of a summary page. So you see in white 3 personal headlines from this individual's results, you see in the blue box headlines about overall study results. Each of these links to more detail. The personal headlines can say things like your sample had a higher level of a chemical than 95% of Americans, using a comparison to NHANES, the National Health and Nutrition Examination Survey. Or it could say you have less of a chemical than others. The report author decides on the priority of the headlines. So when you click through to more detail, you see a repeat of your headline. Then you see information about the chemical sources, about what's known about health effects, strategies for exposure reduction. This chemical results page could also be a health results page in a study that had both chemical and health results. Then users scroll down to their individual results graphs. We've used a variety of graphs. This particular graph type was very well received by stakeholders convened by ATSDR and includes some feedback from them on earlier rounds. So you see the individual's result in orange. Other participants in this group are shown in blue, the study median, the US median from NHANES and US 95th percentile. These NHANES medians can be tailored to a particular context. So if you have the study of reproductive age women, you can get NHANES data for that group. Herb Sussman, who's the original engineer for Derby, created an R package called R NHANES that makes it very easy to tailor NHANES benchmarks. We use graphs because they're a good way to communicate GIST level results. They draw on natural abilities to tell left from right and bigger than, smaller than, things like that. Tables are good when you want to communicate a specific number, but for PFAS, where there are no health guidelines, comparisons are more useful and graphs are a better way to communicate that. If you look at this graph, for example, you can quickly see that this study group, the blue, is falling above the US level for PFHXS, which is associated with firefighting foam. And if in a clinical context, you might want to pay attention to people out here. These outliers would be perhaps a signal that there might be some additional exposure history to explore and possibly some opportunity to reduce exposure. Users can hover over the graphs to get graph reading tips and results details. Graphs can be designed to answer specific questions. This graph you're seeing, for example, shows the decline in a flame retardant in house dust after an old couch was removed. Change over time is something that community members have expressed an interest in. And we haven't built this yet, but stakeholders have proposed the idea that you could turn on and off features of the graphs to answer questions. We think this is a brilliant suggestion. So you could turn on or off comparisons to the community, to the US, to specific demographic groups, for example, men or women, adults or children. You could create summary variables for multiple PFAS, as we did in the STEEP Superfund report to match the Massachusetts drinking water standard. I mentioned that the original summary page has community level headlines. So when you click through to the community headlines, you might see something like this. This is a hypothetical example allowing people to compare levels of PFHXS in different communities. Stakeholders ask for more detail, and the great thing about digital is that we can have a button to click on to get to more detail and not have all the detailed citations adding pages for people who don't want to see them. People highly value information to reduce exposure and protect health. They want to know about both individual and community level action. Medical monitoring guidance could be included here. We've heard in other panels about the need to train clinicians. We've been thinking about approaching this from the other direction, which is helping patients prepare for conversations with their doctor. So the Derby reports provided a great reference that clinicians could use directly. So we've been thinking about how to create a good setting for this conversation by helping patients prepare the information that will be helpful to their doctor. This is a work in progress. So the results pages also have access to many common questions. They provide a contact for an expert if you want to talk about your results. You can see your results in table format. You can print your report. So reports could be added to electronic medical records as a PDF or as data from a CSV file. We find that reports support environmental health literacy in important ways, and they allow researchers to communicate transparently about uncertainty. So there are many places in the reports where you have the opportunity to repeat important messages, like detecting these chemicals doesn't mean you'll get sick. In PFAS reports, you can say what health effects have been linked in past studies, and you can also add, based on what we know now, we can't link your results to specific health concerns for you or your family. Silent Spring Institute reports integrate animal and cell evidence as well as human evidence, and we explain this. Since we don't do experiments on people, we often learn how chemicals may affect health by testing in animals or cells, similar to the way we test new drugs for safety. Here's an example of a smartphone report. This is the report for the Protect Superfund project, a collaboration with Phil Brown. We added smartphone because it expands access in low-income communities where smartphone is the primary access to the internet. You'll see that we added avatars to give it a little bit of a feel of how people are interacting with their smartphones. Our newest report is in Chemicals in Our Bodies and iKids echo cohorts of pregnant moms. This report, we're testing out a very brief little tutorial where people can practice reading their results, and it's intended to increase confidence and stimulate curiosity. We'll see how that goes. The smartphone reports are like the computer-based reports in that they start with big picture and then you can click through to more detail. Advantages of digital reports: this details on demand allows users to access the information that they want. It's easily tailored to community context. It's easy to update with new data or information, which is really great in PFAS context. You can offer multiple languages. I mentioned in a clinical context, data can be displayed, printed, or downloaded. It's efficient and inexpensive to produce and disseminate. I hope you'll check out some example reports on our website so you can get the interactive experience of using them. And you'll also find there a bibliography of about 25 peer-reviewed publications on biomonitoring communications and report back. I leave you with a few final thoughts. Biomonitoring results can be meaningful even when chemicals are persistent in the body and levels of health concern are uncertain. Report back improves environmental health literacy and promotes action to protect personal and community health. And I encourage you to consider that chemical exposure monitoring in highly exposed people might someday become routine. So your recommendations for PFAS can be a step toward including environmental health as a part of patient care, a vision of precision medicine that includes environment as well as genes. I'm very grateful to the many, many partners who've made this research possible. Thanks to everyone, and I look forward to further discussion.
Excellent. Dr. Brody, thank you so much for your knowledge and experience in building these report back components. I know they're used by numerous people, probably across the world, the globe. So now we'd like to take some time to offer questions from the committee. So I'm looking for hands. And if there aren't, I'll give it a moment, but I do have a question. You said you had considered our task as clinical guidance, and you had considered this. So I would love for you to just talk us through what you considered. I know it sounds like you steered towards the giving more information for the patient to consider and their role with the clinician. But what if you, in thinking about the clinician, how would you see a clinician using Derby? Is it possible? Is it a possibility?
Yeah, thanks for that question. So the physician could be the one who asks for the exposure measurements to be taken. Right now, I don't know if right now I don't think we have good systems to make that easy, but it could be a recommendation of the committee to create a system where doctors could become part of a monitoring program where it would be easy to order a test result for a patient if the patient wants it and they thought it was warranted because they're in a highly exposed situation. The Derby reports themselves are like a library for doctors, so they can use it as a reference. We can put all of that content on the internet so doctors could access it directly in the absence of personal results. And we have seen patients bring their reports to doctors, so that's another way that the Derby reports can be useful in a clinical context.
Excellent. Chris, I see your hand is up, and then we'll go to Ned.
Thanks, Dr. Brody. That was fascinating. I didn't realize that there was so much good information out there. I'm curious if you've done any follow-up with providers. So when a patient brings in the information you showed that could be useful to a provider, if you found that providers have found that it is useful, if they've needed more, if they've wanted less, or what their reaction has been with the patient providing that level of information to them.
We have that question too. And in fact, we just have a brand new NIH grant in which we will be able to explore that. So I don't know the answer yet. Although in the Protect Superfund project, that is a clinic-based study. And we have talked to clinicians in that study, and they were quite positive about the personal reports. But I think that's an important, bigger research question to learn more about the best way to incorporate report back into clinical care. That's just beginning, and you guys are on the forefront.
Good. Thank you.
Ned?
This is very helpful. I'm curious, just from other settings and other experiences, and so kind of the last question is, do you think that this acceptability and overall findings from your research is a reflection of the current time, or that it's changed or is changing over time? But before I ask that, the issues are a little farther upstream. So in doing genetic work, we do know that there are people with monogene diseases that don't want to be tested because of the impact of a positive test. We also know that a lot of genetic counseling is upfront before the person gets tested, so that the patient actually thinks through the process.
Yes.
And makes the decision. And then I remember a lot of work we did in the early days of tandem mass spec for newborn screening about, their TMS actually can detect at least twice as many conditions as are currently on the list that are reported back. And most of the time in the US, the rest of the abnormalities aren't reported. And in Europe, at least when we were doing the work, even those that might have been identified, but for which there was no treatment, there was some kind of activity to not report them back. And a study that was done in Quebec that showed that most parents, at least the majority, if there was nothing that could be done about the condition, weren't sure they wanted the results back. And so that's why I'm kind of curious about the spectrum of other responses.
Yes, we've written about the right to know or not know. And that is the reason for the informed consent phase. So sometimes in studies that we've collaborated with, sometimes they address that at the beginning of enrollment in the study. Sometimes they address it for the first time or repeat it before people get their results. So, and that gives the opportunity to lay out reasons you might want to get your results or you might not want to. We have found in the National Academies report also has found very, very high fraction of people want their results. It's well above 90%.